Dear friends, ladies and gentlemen, it's really a great pleasure and honor indeed for me to be here on a very special occasion. And the occasion is very well known to you. It's a dialogue on ARNI in heart failure. We all know the meaning of ARNI. ARNI is angiotensin receptor neprilysin inhibitor. Very simple. It's just a combination of ARB, valsartan, and neprilysin inhibitor. This is the best combination which is available in the history of the world. It's the most iconic molecule of the century, just 7 years old. But see the history created by its enormous morbidity and mortality benefits, which has been documented worldwide. Ladies and gentlemen, I must say today with a great deal of confidence, heart failure is no more a life failure. A time has come we need to have a paradigm shift in our thinking and in our understanding. We can secure the heart of the heart failure patients who are in millions, not only in India but in the whole world. And it's possible today. If you really want to protect heart, not to go into the stage of heart failure, it's feasible today. So I can say that heart failure is preventable, regressible, and reversible to a very large extent, medically. That's all. I just wanted to make an introductory remark. The second important thing is, what is the theme of my dialogue today? And I think the theme is very well known to all of you by now. Since you might have attended a lot of symposia, conferences, the first theme is to understand and know the power, promise, and potential of ARNI by scientific logistics, demonstrating the enormous morbidity and mortality benefit. How do we remember? Very simple. To remember 6 P's. The first P, most powerful, is a paradigm study. Prove it study. Paragon study. Pioneer study. Paramount study. And recently is a Paradise AMI study. These are 6 powerful P's which we all have to understand what they are. And then there is the evaluate study, which is also very powerful. And beside that, is the CHAMP study, transition study, randomized control data, and meta-analysis data. Huge data. What is the second agenda? The second agenda is to know about the morbidity and mortality benefits. What they are, how do we document it? And number 3, talk a word about what we call as CRR. Is a cardiac remodeling reversibility, which is the need of the hour. You all know the prevalence of heart failure by now. See the world data or the data from our own country, Trivandrum Heart Failure Study. It has been very clearly documented in 2018 that 10% of individuals after the age of 65 are victims of heart failure. And the mortality is 59 to 60% in 5 years. That means 3 people in 5 die. It's a matter of great concern. And the same is the global scenario. I'd gone through the whole data of the world. It's almost similar. They say 50% is the mortality, we say 60% the mortality. But the mortality is very high. One thing more, very very specifically mentioned in the Trivandrum heart failure studies, 25% of heart failure patients recovered who were treated by GDMT guided treatment. So drug treatment is so much of power, which was already perceived by a study like Trivandrum heart failure registry data. And that's how it started. Morbidity reduced and the mortality is also reduced. And they covered all the three aspects: sympathetic overdrive, RAS activation, and neprilysin inhibitor. The second thing which I like to mention, that we all know that India is the world capital of uncontrolled hypertension, not hypertension, uncontrolled hypertension, uncontrolled diabetes, uncontrolled CAD, uncontrolled dyslipidemia, and uncontrolled heart failure. And others are sequelae, like atrial fibrillation or stroke. They are all the sequelae of what I just mentioned to you. I remember the data published in Indian Heart Journal was very clear that 42% of patients were not aware of existing hypertension. There is also data published by Ministry of Health, Government of India, ICMR and WHO. They mention very clearly only 10% of hypertensives are meticulously controlled. 90% are not controlled, despite whatever armamentarium of medicines which we use till date, which is also a matter of great concern. So, ladies and gentlemen, uncontrolled hypertension is a global tsunami. In vulnerable patients with vulnerable hemodynamics, vulnerable biochemistry, vulnerable hematology, and vulnerable genetics. A very important message. It was also documented by ICMR that in hypertensive patients, at least there is a one lipid abnormality in 79% of patients, which is a huge data. I think these are the important messages which we see, seeing the prevalent scenario of heart failure and the associated comorbidities. Now, what is the uniqueness of ARNI? Everything is pertaining to a uniqueness, power, promise, potential of ARNI. The most important thing is mortality. Now, if you see the data from Paradigm, Pro or Paragon, they mention very clearly there is an enormous mortality benefit. When we talk of mortality benefit, it has to be a cardiovascular death, 20% reduction. All-cause mortality, 16% reduction. Sudden cardiac death, 20% reduction. So huge. Now, if you see morbidity, heart failure hospitalization is reduced by 21%. Number two, worsening of heart failure, severity of heart failure, and recurrence of heart failure is also significantly reduced. Functional benefits are enormous. When you talk of functional benefit, means it is like 6-minute walking distance or KCCQ score improvement and reduction in the NT-proBNP. They are all the morbidity benefits. Third, most important, is the CRR, cardiac remodeling reversal, which is the most powerful potential of ARNI. These variables are not clinical, they are only echo variables. So anybody who is treating heart failure has to be aware of what echo is all about. So we can see here the first important parameter is improvement in the ejection fraction by almost 10% in 12 months. That's the data. Improvement in LV end diastolic diameter by 12 millimeters in 12 months and end systolic diameter by 14 millimeters in 12 months. Filling pressures like E by E prime ratio improve significantly. LA volume index, if it is more than 34 millimeter per meter square, it's abnormal. It improves by 6 to 10 milliliter per meter square 12 months time. So there is a complete remodeling. Morphological remodeling, what we call a structural remodeling, functional remodeling, E by prime ratio, LV and diastolic pressure, pulmonary artery pressure, they are significantly recovered. And to a large extent, in the meeting which was held just last Sunday, I learned that even the mitral annulus diameter is reduced. The tricuspid annulus diameter is reduced. That means they are all functional. They are not organic. So these are very important messages which we have to see are the powerful potential of ARNI. So we know the mortality benefit, morbidity benefit, and we also know the cardiac reversal remodeling. One more important message, ladies and gentlemen, CRR is purely drug dependent. You cannot stop ARNI. It has to be given lifelong. The only thing you can adjust the dose, but there are some exemptions. When a patient has got a COVID-infected cardiomyopathy, it is reversible. You must stop the drug. Inflammatory myocarditis, you can stop the drug. Peripartum cardiomyopathy, you can stop the drug. Takotsubo syndrome, you can stop the drug. So there are exceptions. Fifth important point, which a lot of people ask me, is ARNI a drug of choice only for HFrEF or for HFpEF or for mid-range ejection fraction or for improved ejection fraction? The answer is for all. The data which I just mentioned to you is documented in HFrEF. But HFpEF, there are three important studies: Paradise study, Prove study, and this third study is your Pioneer study. And these three studies have shown very clearly that functional improvement is possible in HFpEF also. Maybe over a period of time, we can show the mortality benefit also. So functional improvement is seen in HFpEF. That's a very powerful. Sixth point, what are other benefits of ARNI? The other benefits are, it's a diuretic. It causes natriuresis. Number two, it is a drug of choice in hypertension in the future. ACE inhibitors in ARB can be replaced. It's a drug of choice already in registered hypertension. Number three, it can also be used in diabetes mellitus. The insulin requirement is reduced. Number four, it is anti-inflammatory, anti-atherosclerotic, antioxidant. These are all very important parameters which has been documented. It is also a drug which reduces the glomerular atherosclerosis, reduce proteinuria. It is anti-fibrotic. This data is evident by estimation of a marker which is known as ST2. ST2 levels are reduced. CRP levels are reduced. Intimal media thickness is reduced. So they are all the powerful potentials of ARNI. So I made you 5 things: mortality benefit, morbidity benefit, and I also mentioned about the reversal remodeling. Then there is another reversal also which is known as VRR. It's a vascular remodeling reversal. We have 6 billion capillaries and 60,000 miles of blood vessels with 60 trillion cells and 6 trillion chemical reactions with 60 neuropeptides. All are affected by ARNI. That's the power. That's the potential of ARNI. So that's how it is a unique molecule. Now what are the indications? The indications are HFrEF, heart failure with reduced ejection fraction; HFpEF, heart failure with improved ejection fraction; then heart failure with mid-range ejection fraction; acute heart failure, chronic heart failure Paradigm study was done in chronic heart failure, then de novo heart failure, then heart failure after PCI, heart failure after CABG, heart failure in any patient of dilated cardiomyopathy or restrictive cardiomyopathy or even a hypertrophic cardiomyopathy. Even in the patients having a heart failure after CRT, after devices, LVAD, RVAD, or even after heart transplant, ARNI can be used. See the power. So huge list of indications. What are the contraindications? The contraindications are very important to understand. Any patient who is on ACE inhibitors or ARBs, we have to give a washout period of 36 hours. Otherwise, there is an increased vulnerability of what we call angioedema. So if there is a past history of angioedema, please don't give this. Third thing, which is very important, anybody who is CKD in grade 4 or grade 5, CKD, this is contraindicated. Number 4, if anybody's got a hyperkalemia due to any cause, when the potassium is more than 6.5, ideally, we should not worry. If a patient got an acute heart failure, we can titrate the dose, small dose, give diuretics, give K-binder. We also use what is known as petiromer. They are using in USA, not here. But one can use all this. But anybody who is on dialysis, we cannot use this drug. If he is already stage 4 or stage 5 of CKD. Then we should not use in patients who are severely dehydrated. We should not use in the patient who is severe hypotension, where the blood pressure is less than 70 or 80. It itself causes hypertension, but you don't have to worry. The dose varies from 25 milligram BD to 200 milligram BD. That's the dose requirement. So I think this titration is to be done by an expert. It has to be domain by expert, and the treatment has to be echo and clinico guided. Echo all the variables I just mentioned to you, and then NT-proBNP is also a very important guide to manage this. Other contraindications are also there, like pregnancy, lactation, septicemia, multi-organ failure, malignancy, end-stage malignancy. They are all the contraindications, or when the EGFR is less than 20. So I mentioned about everything: indications, contraindications, power, potential, mortality, morbidity, and all the benefits. To conclude, ladies and gentlemen, I must say ARNI is a game changer and will be a game changer as a future molecule of the century in heart failure. This is the only molecule on which we had a hope, and this hope will enhance reduction in the cardiovascular mortality, morbidity, and reversal of cardiovascular remodeling, both cardiac, atrial, ventricular, and vascular remodeling. And this is going to be the future. I firmly believe that everyone should be aware of what we call as heart failure clinic. Just to make you understand in a very simple way, there should be at least 5 components in the heart failure clinic. I'm sure we have the industry, we can take their help. Number 1, there should be a portable machine of echo. Without echo, we cannot diagnose heart failure. Number 2, it should contain a so-called NT-proBNP detection machine. It hardly costs anything, and we can get the report within 10 minutes. Number 3, it should have an app, heart failure app, getting the information. And number 4, there should be a checklist. Checklist is very important since we have to titrate the dose. And number 5, all these patients should have some kind of estimation like ST2 or NT-proBNP, urea, creatinine, and potassium. If we have all the things, our heart failure clinic will run like a hot cake in the future, and we will become a huge center to help the society in reducing the morbidity and mortality. I also say I'm very happy to share today that our next textbook is coming up in next year, And the title of the book is Advances and Revolutions in the Heart Failure, which carry 54 chapters on only ARNI, 48 chapters only on SGLT inhibitors, and more than 20 chapters on bisoprolol, and almost 7 chapters on ferric carboxymaltose, and very few chapters on CRT, devices, LVAD, RVAD, and heart transplant and mitral clipping. Everything will be covered. But the time has changed that we have to think in terms of GDMT guided treatment. The 4 pillars, I call it 5 pillars. 5 pillars should be known. They are the most robust pillars. Number 1 is ARNI. Number 1 is ARNI. Number 1 is ARNI. Number 2 is SGLT inhibitor. Number 2 is SGLT inhibitor. Number 2 is SGL2. Number 3 is beta blocker. Bisoprolol or metoprolol. Bisoprolol or metoprolol. Bisoprolol or metoprolol. And number 4, MRA or loop diuretics. And number 5, don't forget in India, ferric carboxymaltose. I documented number of series of patients who were CRT negative because their iron level was low. When the iron was substituted, they became positive without any manipulation of CRT. So see the data. I think it will teach us over a period of time. So filling pressures are very, very important to be evaluated, E by prime ratio. And I think a time has come, we have to enhance the awareness in the masses by print media, newspapers. Why not? Television shows and dialogues in digital media. That's the future. And I think a time has come, if we change the perception of people acting at the level of primordial, primary, secondary, and tertiary prevention of heart failure, we are going to be a winner. And heart failure will not be a life failure in the future. And my last message is, ladies and gentlemen, every one of us should secure our heart. Why simple drug like ARNI, which is available as Secumada, very simple. So if you use Secumada in a very methodical manner, in a protocolized manner, protocol is very important. You can't treat erratically by your own ideas or your own personal experiences, no meaning. It has to be algorithm guided. You can have your own algorithm in India based on what we saw in the European algorithm or American algorithm or American Heart Association algorithm. Thank you very much for giving me this opportunity and honor to interact with you on a very, very special dialogue of ARNI dialogue in heart failure. Thank you.